Let's now talk about the operative steps. So how would we do a phacoemulsification? First of all, we do the preparation and the draping. So we just put the speculum to open the eye, and then the eye is prepared and anesthetized. Putting the just forget that, the antiseptic. What is its name? Can you just tell me what is the name of this? Yeah, betadine. Yeah, exactly. The betadine solution. So we do with the betadine solution from the surface of the globe in order to sterilize the globe, and this was proven by evidence base that it will decrease the highest factor that will decrease the incidence of endophthalmitis. So the povidone iodine, yes, exactly. It will be placed in this manner. So we are placing it into the conjunctival sac, trying to avoid the cornea to prevent any corneal toxicity, and which will can impair the visualization. Opening the speculum in order to, and opening the lid in order to allow to prevent any tension, high tension over the globe, which can increase the pressure within the globe, leading to more incidence of complication. Then we make the incision. So this incision can be either clear corneal incision or scleral incision. So we use a device or a knife called the keratome. This keratome will open the globe. We can stabilize the globe by the second hand by several methods, like this ring stabilizer, or by a second instrument like by cotton tip or by forceps. So this can be done. And then we enter through enter with the phaco tip, or enter with this keratome. This should be matched to the size of, or the width should be matched to the size of the phaco tip. So it can be 2.6, 2.8, 3, 3.2. And so good architecture of this incision is essential for a safe surgery. So this is how would we do the incision. Just making the incision at the necking of the blood vessels, the limbal blood vessels, making the incision width almost like the length. So making it also, there is what's called uniplanar or biplanar or multiplanar or triplanar. So to make the wound self-sealing at the end of the surgery. Another example. So we are pointing the tip of the keratome first toward the apex of the cornea, because in order to respect the curvature of the cornea. However, if you just make the incision parallel to the iris plane, this will end up by a short tunnel. Another example. So we see this blood vessels, this slight hemorrhage or slight blood vessels at the site of entry. This is a good sign that that this will help in the healing of this wound. Another method of creating the tunnel is not to go through the cornea, because the corneal tunnel can also have some its complications, specifically the higher incidence of astigmatism. So scleral tunnel can be done by using a crescent blade. So this crescent blade will make a pocket in the sclera, like around 2.5 millimeter from the limbus, and then you are by sweeping from side to side movement in order to create this tunnel like that. So doing limited periotomy, like opening of the conjunctiva, then cauterize, and measure the scleral tunnel around 2 millimeter to 2.5 millimeter. Make the initial incision with a sharp knife called the MVR or the super blade. Then creating the tunnel with a crescent knife from center to periphery until we open the anterior chamber. You see this side-to-side movement is very important to avoid dissection in different plane. And finally, open the anterior chamber. After opening the anterior chamber, you form the anterior chamber with viscoelastic. So remember the viscoelastic that we just mentioned. Now you have access to the anterior chamber. And once you open the anterior chamber, the tension is becoming soft. So you want to inflate the globe by a substance that will form the anterior chamber, will form the globe, increasing the intraocular pressure. So you do, or you inject the ocular viscoelastic devices. So this will result in flattening of the anterior chamber and anterior chamber maintenance. The dispersive is used for coating the endothelium, specifically for patients with dense cataract, where we are expecting to have high ultrasound power. And we use the viscoelastics or the cohesive for flattening of the anterior capsule, especially in the wide cataract. So we inject the viscoelastic by going through toward the 6 o'clock, then inflate the visco bubble as we are moving outside. This is how would we do the viscoelastics. Again, so we enter, inject the viscoelastics, and then we enlarge the bubble as we get out of the eye. Sometimes we needed to stain the anterior capsule. Sometimes this is for cases of dense cataract or for wide cataract, where we don't see a good red reflex, because red reflex is essential in order to make the capsulorhexis. So in this cases, we stain the capsule by the trypan blue stain. So after doing the peripheral incision or peripheral paracentesis, we inject first the air in order to protect the endothelium, then this blue stain called the trypan blue stain in order to stain the capsule and be able to visualize the capsule during the capsulorhexis. You just leave it for a few seconds till you make sure that it will stain the anterior lens capsule, and then you enter with a cannula in order to irrigate and wash. So you don't leave this stain, you remove it because it is toxic to the endothelium. Paracentesis can be done during the start or to the end. It is a surgeon preference. It can even some surgeons defer it to the like just at the onset of the phacoemulsification or just before phacoemulsification. So what are the paracenteses? They are like 1 to 1.5 millimeter incisions placed at the temporal and nasal side. So it is usually 3 clock hours from the main incision, carried by either the tip of the keratome or the MVR blade or the super blade. They should be done parallel to the iris surface, and they should be placed at the surgeon preference, where he is will be making the manipulations of his instruments more easy for him. Another example. Another example. So here we can use the keratome or the MVR for some tricks like doing the initial opening of the capsule. After that, we got to the crucial step. It's called the continuous curvilinear capsulorhexis, or the CCC. So the continuous curvilinear capsulorhexis is basically the anterior capsule opening that we fashion in order to facilitate our maneuvers into the lens later on. They can be made either from the main incision or can be made from the side port, and they can be fashioned using a cystotome or a bend needle or a forceps or even a combination of both. So the ideal size of the capsulorhexis, it should be around 5 to 5.5 millimeter. This will be the best for to prevent further complications of the continuous curvilinear capsular access. So we needed to have like an ideal size of 5 to 5.5 millimeter. We needed to be more central. We needed to be curvilinear, so it will be continuous with no breaks. This will be the ideal. And if we have difficulty in visualization, we can use the trypan blue stain, as you can see here. So let's see how is the anterior capsular access is done. So here we are doing by the capsular access forceps, initiating first a capsular opening, then holding, grasp and re-grasp the edge of the anterior capsule to continue the anterior capsular opening, making it central, making it regular, making it continuous, and around the size of 5.5 millimeter. Another example where the capsular access is made by the cystotome. So this is a bend 27 gauge needle, which can be used to initiate and also continue the anterior capsular opening. Or we can use a combination of both. So everyone has its advantages and disadvantages. So you can see here that we are placing the cystotome from the side port. We use that from side port for sometimes in order to minimize the lost anterior chamber, to minimize manipulations at the main wound, especially for case of intumescent cataract. So you see here that the rex's edge is a little bit extended, reaching here. So the capsular access forceps is better used here now to initiate what is called ripping of the edge of the rexes to rescue the rexes from extension. So we can use combination of both. Another example. I think that this was the previous one. So it is just for demonstration, how the edge of the capsular access was running, and we now placing the capsular access in order to do ripping and retrieve the edge of the rexes. Okay, so now we created the anterior capsular opening and we are now ready to deal with the lens. The first now method is causing the hydrodissection. What is meant by hydrodissection? It is just a separation of the cataractous lens from the capsule. So we are dissecting the lens away from the lens capsule. Why we need to do this? Because if we are just trying to emulsify the nucleus or dealing with it while it is adherent to the capsular bag, this will damage the capsular bag. It will result in rupture of the capsule. So we need first to make the nucleus freely mobile within the bag by separating it. How do we do this? We do it by injection of BSS under the edge of the capsule, so that this wave of the BSS will continue and separate the whole lens and nucleus from the capsule. So you use a small caliber needle like that of the Healon viscoelastic in order to inject the fluid, this injection should be steady and shouldn't be very rapid or vigorous, and should also be large bolus of the fluid. Should be steady injection of the in order to create waves, as I'm going to show you right now. So this is the principle. We are placing this needle in order to inject the fluid, which will pass under the lens till it come from the other side, meaning that the total lens is, or total cortex is separated from the capsule. But before that, we need to do very important measure, which is to this. If we did just inject fluid into the but just below the capsule to separate the cortex from the capsule, this will result in increasing in the intraocular pressure, or the intralenticular pressure, and increase also the anterior chamber pressure. And the anterior chamber is already filled with viscoelastics, which already increase the pressure. But this was important to do the capsulorhexis. But for doing the hydrodissection, it is not important, but even it is harmful, because here is that the posterior capsule is very weak. If we are injecting the fluid, it will just rupture posterior capsule because the fluid will pass through the weak area. So we need first to decrease or to evacuate a little bit of viscoelastics or viscoexpression in order to do a safe hydrodissection. So how do we do this? By just you see this, we're just pressing on the posterior lip of the wound, and now passing the needle under the anterior capsule edge and doing this injection. It will create these waves, meaning that a separation of the lens. Just press on the posterior lip of the wound, then inject. And in order to make sure that the nucleus is freely mobile, we do rotation. Here you see that the subincisional area is not rotated. So here we inject into the subincisional area. Another example where you see that the lens is already liquefied and it is already white cataract with torn anterior capsular edges. So here we are doing very, very gentle hydrodissection in order to avoid the more extension of the tear or more extension of this break. So are there any cases where the hydrodissection is contraindicated? Yes, there is the posterior polar cataract. Remember when we said about the posterior polar cataract? It has a defect in the posterior capsule. So if you did hydrodissection in patients with posterior polar cataract, this may result in rupture of posterior capsule and the drop of the nucleus. So remember that hydrodissection shouldn't be done in patients with posterior polar cataract. So what should we do? We do another thing called hydrodelineation. In hydrodelineation, we place it the same technique like hydrodissection, but we just separate the nucleus from the epinucleus. So why we do this? In order to facilitate the nucleus removal, and in order to protect the posterior capsule by leaving an epinucleus shell or cushion that is protecting the posterior capsule. So we are here separating the nucleus from the epinucleus. We place the needle in between the nucleus and the epinucleus and inject in order to allow the fluid to pass to the other side. So how do we make sure that we did a successful hydrodelineation? Is by a sign called the golden ring. A golden ring. Dr. Sinali, what is hydrodissection? Exactly, this is what I was mentioning. Hydrodissection is just separating the cortex from the capsule. And we do this by injecting the fluid. So we injecting the BSS between, for the hydrodissection, injecting the fluid between the lens and the anterior capsular edge in order to allow the fluid to pass between the cortex and the capsule until it is emerging from the other side. And we know that we did successful hydrodissection by waves, by presence of the previous waves. Let me show you these waves again. You see, these waves which will pass to the other side. This means that It will be more clear in the previous example here. So pass below the edge of the anterior axis. You see this wave? This wave is separate of the fluids is separating the lens from the posterior capsule. So we have to see this wave to make sure that we did successful hydrodissection. For hydrodelineation is we are placing the fluid between the nucleus and the epinucleus, and this will result in separation of the nucleus from the epinucleus, like that. So we first did hydrodissection by passing below the capsular edge. And now between the nucleus and the epinucleus, you see this golden ring? This golden ring meaning that the nucleus is separated. So this is a hydrodelineation. So the sign of hydrodissection is the presence of waves or appearance of waves that will separate the cortex from the capsule. But the sign for the successful hydrodelineation is the presence of this golden ring. Let's see another example. So hydrodissection is done first, and then hydrodelineation. You see this golden ring. This means successful hydrodelineation. Another example. Hydrodissection is done first. See this wave, then hydrodelineation, meaning that this ring is formed. Then we do rotation to make sure that the nucleus is totally separated. After doing a hydrodissection and the hydrodelineation, then we are ready for phacoemulsification. We just put some viscoelastics to protect the corneal endothelium. If we haven't done the paracentesis, we can do it right now because we are going to need it for nucleus disassembly and the nucleus manipulations. So now we need to attack the nucleus. We need to emulsify the nucleus. We have different strategies for nucleus disassembly or nucleus removal. So basically, what we need is to just remove this nucleus from the anterior capsular opening. So the removal of the nucleus or the nucleus disassembly is just to remove the nucleus piece by piece. Why we do this piece by piece, or why do we do fragmentation of this nucleus? To minimize the phacoemulsification injury, because the phacoemulsification energy, the phacoemulsification energy can put the corneal endothelium at risk and also can put the posterior capsule at risk. So what are the techniques that we can use for the nucleus disassembly? First technique is called the divide and conquer. Divide and conquer. What is a divide and conquer? Divide and conquer is making a groove in a vertical groove like that, and then doing a horizontal groove, dividing the nucleus into 4 quadrants. And then, so this is what's called by divide. Divide the nucleus into 4 quadrants. Then attacking the quadrant. So it will be conquer, like emulsifying quadrant by quadrant. This is the basic technique for nucleus disassembly, by doing a crochet groove and then attacking the quadrants by quadrant. So this is actually not my, or usually I don't use the divide and conquer. So I try to find a video for divide and conquer, but unfortunately I couldn't find. So I don't know if this is a divide and conquer or not, but I don't think so. This is actually for the Rexes. I don't know why it is here. Okay, so I think that there is no divide and conquer here. There is another technique called stop and shop. Stop and shop, this is another technique for nucleus disassembly where we are doing a horizontal groove, oh sorry, a vertical groove. This is what I call sculpting or making a groove. For the divide and conquer, we do a groove on the perpendicular to it. But for this technique, it's called stop and chop. And the will be this stop and chop where we are going to stop dividing and then start chopping, attacking a large piece of chunk of nucleus, and with the chopper trying to grasp it. Trying to find a safe area where there is a large nuclear chunk by rotation of the nucleus in order to embed, and with the help of the chopper, the second instrument, we are dividing the nucleus. And once you are dividing the nucleus, you are now can proceed with the surgery by dividing the nucleus by several small pieces in order to emulsify them and complete the surgery. Try always to be in the safe area, in the safe zone within the central part of the pupil, or at the iris plane in the center, so that you are not too close to the endothelium or not too close to the posterior capsule. So shopping, as you are doing shopping and emulsifying, shopping and emulsifying by the phaco tip. So here we are finishing the whole nucleus. And then this is the remaining, the epinucleus. But this is still a nuclear quadrant here. Always watch your phaco probe not to get out from the main wound, because this can make the wound at risk of wound burn. So it's always try to be in the center. This is another technique for nucleus disassembly, which is the quick chop. This is where we don't create a groove or we don't sculpt, but we just proceed with chopping or cutting the nucleus into halves by impaling the nucleus into the nuclear material and chopping. So now the nucleus is divided into two quadrants and one hemiquadrant, or one heminucleus, and the heminucleus is now divided into further two quadrants. So now we have 4 quadrants. Now we are attacking the quadrants, emulsifying them one by one. As we are emulsifying, we emulsify and chop with the aid of the chopper. So till the last quadrant, I think that there is a slide for horizontal and vertical chopping techniques here, but I don't, it is either in the FRCS3 presentation, but I don't know if I put it here or not. Dr. Marwa is saying, how can I adjust the microscopic illumination during the surgical steps? Well, actually, you can either use the direct illumination or the red reflex mode. You can use it depending on your preference. So sometimes you can use them in during capsulorhexis. The red reflex will be better for the capsulorhexis, and for the nucleus management, you can choose any one of them depending on your preference, either the direct illumination or the retro illumination from the fundus, like that. Yes, Dr. Yahya. So here is a vertical chopping. So if I didn't put the difference between the vertical and horizontal shopping, let me try to explain more between the difference between the horizontal and the vertical shopping. So for the horizontal shopping, we are placing the phaco tip. We are making we are impaling the phaco tip, and then with the horizontal chopper, would tend to be small with a blunt end. Here, this is very important. It has its cutting edge from inside. So we are making a groove and impale the nucleus, and then with the chopper is going to the nuclear equator and then chop horizontally. So the direction of movement of the chopper is from the equator to the center. Like look now at the movement of the chopper. Still, I'm trying to find bulky nucleus part in order to grasp, so I can make occlusion by the phaco tip. Now you see the movement of the chopper is from the horizontal to the center. This is how we do the horizontal chopping. But the vertical chopping, we do it by different maneuver. It will be like vertical knocking of the nucleus in order to separate. And this is the difference between the horizontal and the vertical chopper, that the vertical chopper has a pointed end and more tall than the horizontal chopper. And it can be especially useful for cases of a small pupil, or where in this case we need to minimize the tension on the zonule, because we don't want this extension of the capsule to be running to the posterior. So I did here what I did here is just to make the vertical chopping, so I don't have to go to the equator of the nucleus and to divide the nucleus. So you see here, it's just you are placing your chopper and try to crack the nucleus up and down, like you are changing your hand direction. One hand is up and one hand is down, so that you are create a line of separation vertically between the two nuclei or two heminuclei. Let me check. I can now show you let me bring the slide of the differences between the vertical and horizontal chopping. I will get it from the FRCS3 presentation after this slide. Actually, this is out of the scope of the MCQ exams. I didn't know that you will be interested to know. So for the FRCS3, usually they tend to ask more surgical details, operative details, but operative details are not asked usually in the second part or in the MCQ exams, usually. Okay, so just hold on for a second. Let me just bring this slide. Actually, it's not a slide, it is a video. So let me show you it to you right now. Okay, let me show you my screen. Okay, so let me show you here the difference between the horizontal and vertical chop. So here is the horizontal chopper is going toward the equator of the lens in order to divide the lens. So its movement is a horizontal movement. You see, the chopper will hook the endonucleus at the equator and then move into a horizontal direction. And then by lateral separation between the phaco-tip and the chopper, then the nucleus will be cracked. So you just bring it from the equator to the center, and then lateral movement between the phaco-tip and the chopper. This will result in cracking of the nucleus. Here you need to be very careful because you are close to to the capsule edge. So this is the disadvantage of this technique. That if you are not experienced enough, you may harm the anterior capsule. You may cause tear to the edge of the capsule. So it is better to start, if you are starting chopping, you should be starting first with a blunt or ball-tipped chopper, a chopper with a ball tip to be gentle on the capsule. This is the vertical chopping. Here, the chopper should be a little bit more long, and with sharp tip in order to embed it into the nucleus. And then by vertical movement, you are moving the chopper down and moving the phaco probe up. So you are cracking vertically. You are cracking the nucleus from the vertical direction. This is useful for case of weak zonion or for small pupil, as I'm going to show you here. The patient here has a small pupil. We are using a pupil dilator ring. That's why we are not able to go to the equator. So we just embed the chopper in front of the nucleus, then lateral separate will cause cracking. So here you see, you are just embedding the chopper within the nucleus. Then after embedding, lateral separation will cause cracking. So you tailor your technique depending on the case. This is also useful for cases of hard cataract, where you are want to divide the nucleus into multiple small pieces. Without too much stress on the zonule. This is a horizontal. So he did a combination between horizontal and vertical chopping. And the case is done. Well, for the soft cataract, we use debulking. Selma, for the soft cataract, the key is to do good hydrodissection. For if you did good hydrodissection with hydrodelineation, the case is finished. So you will not be able to do stop divide and conquer for patients with a soft cataract. So you just do debulking of the nucleus, or you do it like a supracapsular phaco. So you prolapse by hydrodissection, you prolapse the lens into the anterior chamber so that you can debulk it and fragment it, or you can do what's called shipping. Sorry, not shipping, like chip and flip. So you are eating it like you are saucerizing the nucleus and then flip it to flip and then eat it. I don't know if I have a video for that or not. I don't think I didn't bring a video for. So for me, if you are asking my technique, it will be the best, the safe thing is to do supracapsular phaco. The nucleus is soft, it is not it will not harm the endothelium, and also you will be away from the posterior capsule if you are afraid to hold the nucleus to the posterior capsule and afraid that you will hit the posterior capsule by chance. So the best is to do very good hydrodissection, trying to get the nucleus in the anterior chamber. If this didn't happen, then the key here is to have low vacuum. So if you have a low, the problem here is that when most of surgeons find that the nucleus is not getting to the phaco probe, or it is emulsified by the phaco probe, and you are not able to have vacuum, or are not able to grasp the nucleus in order to chop it. So what you do? You think that the problem is in the vacuum, so you increase the vacuum. And what will you find? That the nucleus is eaten by the vacuum, not by the ultrasound. You didn't even reach to that level. So the key here is to have low vacuum, not high vacuum. If you're having low vacuum, you will be able to grasp the nucleus. And you will be able to hold it, having strong hold, and then chopping. If this didn't happen, always try to find a safe zone in order to grasp the nucleus. If you, after multiple attempts, if you are trying to grasp and regrasp the nucleus, trying to hold it for chopping, and you haven't been able to do so, it will end up by that the nucleus will be totally saucerized. So what will I suggest here is just you pass the visco cannula under the edge of the anterior capsule and inject, as if you are doing hydrodissection. What you are doing now is viscodissection. You are placing the visco between the nucleus and the epinucleus and the remaining and the capsule. So you will find that by physics, the nucleus will be coming out from the capsule. You got it? You're welcome. So sorry for that. I think that I missed to put a video for the soft cataract. Okay, for the step 10, after removing the nucleus and the epinucleus, you will have some cortex is remaining, and this can be done, can be removed by two techniques, either by manual technique or coaxial aspiration. So this is the bimanual. You are placing the two ports, irrigation and aspiration. Always irrigation is coming first, or is introduced first into the anterior chamber, while the aspiration is by sweeping movement will grasp the cortex and just pull the cortex and remove it from the center. Don't remove it from the periphery. So just sweeping movement, engage the cortex and eat in the center. Sweeping movement, engage and eat in the center. And always take the cortex from above. Don't make the cortex which is at the posterior capsule tempt you to engage it. Always go to the equator and engage from the equator. Otherwise, it can end by a posterior capsular break. Okay. So this is an example of cortex removal for patients with a small pupil, which can sometimes be very challenging. So you use your irrigation cannula as a second instrument in order to dilate the iris, in order to retract the iris and try to check for what is left behind, what is the cortex which is left behind. So sweeping, engaging, and eat in the center. Okay. After that, after removing the cortex, now we are ready for implanting our intraocular lens. We can use it by an injector like that. It can, in the past, it was used by like implantation forceps, which was used to fold the intraocular lens and implant it. Nowadays, most lenses are can be implanted with an injector. So you just place the intraocular lens within the injector and implant it into the anterior chamber with the bevel down like that. So let's see. So after doing the irrigation aspiration, you can implant under hydro by placing the irrigation on in the anterior chamber. This is for the hydrophilic lenses. And or if you can use second instruments like a support like Synesky or a second instruments in the side port in order to make a counter traction while you are implanting the lens. So you are just putting the cartridge with the bevel down, inject the intraocular lens into the bag, and then dial the anterior chamber in order to place the optic and two haptics within the capsular bag. After that, you have already implanted the intraocular lens, so you have some viscoelastics are present. You need to remove them because if you leave them, they could rise the intraocular pressure. So removing the viscoelastics by normal way, like by just doing a simple irrigation aspiration. So here the haptics, the trailing haptics was away outside the bag. So I just dialed and rotated the IOL in order to place the haptics in the bag, and now removing the viscoelastics from behind and from above the intraocular lens in order to prevent any spikes of rise of intraocular pressure after the surgery. After removing the viscoelastics, the last step is to do wound closure. So we needed to close the wounds because if we have a leaky wound, this can result in many complications, most importantly endophthalmitis. So we do it by one of two methods. One is the stromal hydration. So this will be the standard, just injecting BSS within the wound edges. This will be enough. But for some occasions, we may need to suture this wound. Okay, so these are the phaco steps, step 12 or 13. Let's now count, Dr. Hager. So the phaco emulsification is like a pyramid. Every step is dependent on the previous step. If you do the previous step well, you will prevent the complications or difficulties in the next step. Like for example, if you do the incision well, you will have good surgery, good smooth forward surgery. But if like you did a leaky wound, then you will have like the iris is prolapsing every now and then. the anterior chamber is lost every now and then if you have large wound, or if you have short or shallow wound. If you have a long wound, this can result in difficult manipulations, difficult capsulorhexis. Then the step 2 is you do the capsulorhexis. If you do the capsulorhexis well, it will facilitate the nucleus removal. And if you do like small rhexis or extended rhexis, then this will modify your techniques or make the surgery more difficult or more risky of extension of this capsulorhexis to posterior, leading to rupture of posterior capsule. If you do the hydrodissection and the hydrodelineation well, it will separate the nucleus. But if you didn't separate the nucleus, you will have very rough time trying to manipulate the nuclear fragments and trying to get them out of the capsule, because they will be sticky. So this will result in difficult surgery. If you do the hydrodissection well, then you do the nucleus disassembly. If you do the nucleus disassembly well, you will have no problems. If not, then you are risking to do rupture posterior capsule. If they are not in the safe zone, if you are not respecting the anatomy, being aware of your boundaries, like where is the anterior capsule, where is the endothelium, where is the posterior capsule, so you are risking the surgery. Then step 5 will be the irrigation aspiration. Again, this is where you may be surprised to know that irrigation aspiration is one of the most crucial steps after the nucleus disassembly, as simple as it looks, but this is where the surgeon is losing his concentration. He is maybe doing some trivial errors causing rupture of posterior capsule. So watch carefully for irrigation aspiration. Finally, the IOL implantation, also dependent on the previous steps. So if the patient had any problem within the bag, like dialysis of the bag or extension of rhexis, so this will jeopardize the IOL implantation. And finally, closure of the wound. So this will be also the tip of the iceberg or the tip of the pyramid. So you are doing the closure of the wound by stromal hydration, but like if you are doing a bad incision, or you've had like a wound burn because of excess phacopower, or if you are doing phacoemulsification near the wound itself, this will result in poor closure of the wound. The wound will be leaky, resulting in the that you need to suture this wound. Okay. Okay, so Dr. Islam, is stromal hydration increase the astigmatism? Well, it will be, even if it increases the astigmatism, it will be better than the suturing. So the suturing will definitely change the refractive media of the cornea, but the stromal hydration will cause little or no astigmatism at all.